Welcome to the DxTx Partners Podcast. And with me today, really lucky to have Dr. John Prunskis. Dr. Prunskis is a physician, a professor, a healthcare AI advisor, a business leader, and a diplomat. Also, fortunately, one of the founders of DxTx Pain and Spine. So we're really happy to have you, Dr. Prunskis. And
Thanks. Happy to be here.
awesome. Where are you joining us from today? Because I know you travel all over.
I am in Florida today.
Florida. So, where have you been dedicating your time these days since you've reduced your time practicing medicine?
First of all, I want to say I miss my patients and my staff tremendously. And right now, where I'm spending my time is in several projects. Healthcare artificial intelligence. I'm advisory board of one of the largest healthcare AI companies based out of Palo Alto right now. I'm in the process of forming a startup in the longevity AI data-driven space. My whole career is based on practicing data-driven medicine, which ultimately is what allowed me to advise 3 U.S. presidential administrations, among other things. Also, involving myself in a capacity as an advisor at certain levels in the federal government as well as state governments, and then exercising every day at least 30 minutes and focusing on some longevity issues that are proven, which is dietary modification and other things. So I'm probably working now about 4 to 5 hours a day on projects, and then the rest of the time reading, exercising, and things of that nature.
Awesome. A lot of interesting topics there just in that little snippet. Let's go back kind of like to the beginning. What inspired you to become an interventional pain management physician? And then how have you evolved as a physician over the years?
After I finished my residency, I stayed on at the University of Chicago for a fellowship, and just so happens that my fellowship director, who was a year ahead of me on the academic track, ultimately wound up to me, my wife of, I think, 34 years coming up. So when I went into private practice, the hospital that I went to in the suburbs of Chicago, they had a request system where surgeons or patients could request an anesthesiologist. For some reason, I was the most requested anesthesiologist in the operating room. But then also, because of the training I had, I was asked to consult with patients who had various painful conditions. And goes back to the late 80s, early 90s, so a long time ago. So my days would start, 6:30 in the morning and kind of end at 9:30 at night. When I'd be done with the OR, I'd have my pain clinic. And the main focus then and then and now, and obviously the technological advances have been substantial in that time period, was as much as I could data-driven techniques to identify the source of someone's pain, and then limiting or eliminating the use of opioid narcotics. And for 2 decades, my colleagues thought I was wrong. I was a contrarian, meaning that for that time period, we had a huge crisis in the United States, as many people know, where physicians were writing large quantities of opioids, stating that if a patient did not have a motor loss, in other words, they could move their hands and arms and whatever, just write narcotics and don't worry, they won't get addicted or they won't get, habituated to them. And that just never made sense to me or my wife, who of course is also a very well-known worldwide pain physician. And but our interest was always in data, elimination or reduction of opioid usage, and identification of the source of someone's pain and fixing it. So that core concept has not really changed. But of course, with the advances in technology and data and procedures, we're able to help many more painful conditions than we did 40 years ago.
Interesting. So, you talked about the advancements in technology and procedures. How do you define the role of the interventional pain physician outside of just the procedural side?
I like to use an analogy now. It's evolved really to the point, similarly to, I would say, cardiology and cardiac surgery. So if someone has a chest pain, the first person they might go to is their primary care doctor. Then they'll go to a cardiologist. They're not going to go jumping to a cardiac surgeon. And so I view our current job as being somewhat gatekeepers for painful conditions in the spine area, to be sure, but also any pain that someone's had, I would say, for at least 2 weeks. Now, obviously, if it's excruciating pain, the patient can come in right away. There are some times where we will need to engage a specialist right away to make sure that there's not some urgent need for a surgical condition or evaluation. But right now, our role is principally early on and diagnosing the source of the pain, and then selecting treatments and modalities would follow based on data.
Are there any, particular cutting edge technologies right now that you see are most exciting in the pain management space?
There's multiple and changing all the time. The advancements in neuromodulation and what some people call spinal cord stimulation. I sometimes call it epidural stimulation, because sometimes patients, when they hear spinal cord, they get a little bit anxious. But I explain to them that really it's the same as an epidural injection in the same area. Especially when we do the trial, there's no incisions. It just goes, this tiny catheter goes through a needle into the epidural space that is injected multiple times per day, thousands of times per day, probably in the United States. And then the technologies that has provided to relieve patients' pain. But then also it starts with the fundamentals of a sound history, physical examination, appropriate use of radiological and other testing, to formulate an opinion where we're now, through many procedures, we can now percutaneously or with minimal incisions fix the source of the pain without substantially changing the anatomy. And as we know that, surgery can irreversibly change someone's anatomy. And there are some instances where that's necessary. But now we see that those types of surgeries every year becomes less and less indicated because of the newer technologies we had. We can now do, through very tiny incisions, fusions of the spine that, again, don't change the anatomy, and we can reverse those. There are changes where if people have what's called a compression fracture, we can, through a needle, help fix that problem. We have peripheral stimulators that also, can be removed to assist in helping people with painful conditions, all while maintaining function, reducing opioids, and in most cases, not changing the underlying anatomic structure that, again, surgeries can sometimes irreversibly change. So it's a super exciting space in that regard.
We get the opportunity to, one, we have a fairly large network around the country of affiliate network, but we also get to evaluate a lot of practices. And when we're looking at practices, we see people all over the place that are doing just basically the bread and butter. And then some people are really, kind of pushing the envelope and working with emerging technologies. Are any of the emerging technologies and modalities that you see will eventually become just standard of care that we'll be seeing everywhere?
That's a great question. One thing, as we've grown now, I believe, to 60 locations in 10 states, I've really seen that there's a bell-shaped curve, even in physicians and physician engagement into the latest diagnosing and technology. We're fortunate at DxTx to see that, and then to some degree help with the education of physicians who perhaps need to be exposed and understand some of the greater techniques. This has been a surprise to me. And so when I attend meetings, I will sometimes, hear a speaker who will have great content, but it's interesting when they go back to their practices. What I've learned is they don't always practice what they preach, if you will. And I've tried to figure out, why does that occur? And I think what it is at a national meeting, a speaker has done research. He or she wants to appear smart, up to date, and they deliver a good lecture. But then when they go back to their community, in some cases, they change their practice. And that is not something I understand. And one of the things that is a value add to a patient and a physician who is in DxTx is that we are available not only to identify areas that they might need to expand their scope of practice or understanding, that in other settings, once a doctor hangs their shingle up and they finish their boards and pass their boards and become board certified and have finished their fellowships, they really are practicing in a way that they feel they want to. I am not sure that that's the best model. I think the much better model is the one we have at DxTx, where we have tremendous respect for what the physicians have done. And to get to that point, it's brutal. It's years. They basically have given their 20s, from their age of 20 to the age of 30, they've been focused on studies. So there has to be tremendous respect, and we give them that respect. But at the same time, now that they're in their 30s or 40s and they're on their own, so to speak, education can't stop. And DxTx is something, DxTx Pain and Spine is something that provides that structure and also the engagement for physicians in our network to stay current, to learn from those who are doing other data-driven procedures and evaluations that perhaps they did not see in their residencies and fellowships. And so that structure throughout DxTx Pain and Spine provides a next level care that otherwise patients might not get if they just go to a, quote, board certified interventional pain physician who's just out on their own practicing.
Well said. Chronic pain is often invisible and misunderstood. How do you advocate for patients facing skepticism from both healthcare providers and society as a whole?
There are ways that we can now dial in to better understand painful conditions. Taking a detailed history and physical examination are critical foundations for identifying patients with painful conditions, along with appropriate radiological imaging. What I mean by that is MRIs, X-rays, sometimes nerve testing, sometimes some blood testing, sometimes other tests. And so we can really now drill down on identifying the source of someone's pain. And over in our practice, and again, we now have 60 locations in 10 states, I think it's about 92% or thereabouts of we can identify specific pain generators. There's probably about 8% or less even that have pain throughout their body. And so that could be from metastatic cancer. It could be from rheumatoid arthritis. It could be from sickle cell disease, Crohn's disease. So these are important painful conditions that we call systemic, in other words, multiple systems. But really, that's only, as I said, 8% or lower of what we see out there. In well over 90% of the cases, we can identify the source of the pain, fix it, and eliminate opioid use entirely or reduce it substantially. So the days where it was, again, I've been doing this now, I graduated medical school in 1982, so it's been a long time since I've been focusing on this. The days where, we didn't have such precision to identify pain generators are long gone. So it's a very exciting time. And so now, do sometimes we get surprised, if there's litigation involved and a patient has, for some reason, a secondary gain, can we still get fooled? Yes, we can. But those instances are far and few between right now. So the skepticism about these painful conditions, the ability to diagnose the source that some people have right now is really misplaced. We especially at DxTx Pain and Spine are expert at identifying the source.
Dr. P, I'm going to shift a little bit here, and I'm going to pump your tires a little bit, because in my career, I have never met a physician that is engaged in the entire space, meaning policy, reimbursement, access to care. So my next question is, what policy changes at the national or state level would be most beneficial for patients suffering from chronic pain?
Sure. So I've been fortunate, as I mentioned, to have input into now 3 U.S. presidential administrations and multiple state governments through multiple governor's offices, and also now engaging with certain U.S. senators and congressmen, not only on interventional pain issues, but also on healthcare, artificial intelligence issues. And the perhaps the most significant events, I'd say, that have moved the needle, no pun intended, of course, is my, I think, my first time I was invited to the White House is always memorable. I think anyone who gets that first invitation to the White House never forgets it. You might not remember your third or fourth invitation, but you sure remember that first one. And I remember taking a picture too, because I wasn't sure if I'd ever get invited again. But that was with the administration of President Obama, where at that time, as I mentioned, I was viewed by my colleagues as a contrarian. And when I'd speak at national meetings, the other 3 or 4 physicians that would be on the speaker's platform or stage were advocating for the use of opioids. Don't worry, patients won't get addicted, if they have a real pain. And I would blatantly just disagree. And in the audience, 95% of the audience would disagree with me, thinking that we could go ahead and write opioids. Those other physicians, all of them wound up either having their licenses limited. They took plea deals with the Department of Justice, et cetera. And we all know those stories. There have been, Netflix series about what happened. And I was on what I say the non-sexy side of that equation, because we banned pharmaceutical reps from our clinics if they were selling opioids. Many people couldn't figure out why we're a pain clinic, right? So we're supposed to be writing opioids. No, we're a pain clinic, but we're working to diagnose the source of the pain. And so when the data started getting published by the insurance companies in the Chicago area, and President Obama, as you recall, was from Illinois, from the Chicago area, it was logical for them to have a greater awareness of what was going on in Chicago and Illinois. And they invited me in to the West Wing to talk with their senior advisors on what it was we were doing differently, where we're getting the best results in the city, including academic institutions, yet we're prescribing the least amount of opioids. And so that I shared our expertise, but then in the first 2 weeks after Donald Trump won his first election in 2016, I got a phone call from the transition team asking if I could fly to New York and meet with them. Same question. We've heard about you. What are you doing differently? We're losing 100,000 people a year to drug overdose deaths. You're identifying the source, you're prescribing for opioids. What are you doing differently? And so at that time, they had asked if I would consider a full-time role in Washington. I was honored. I was not expecting that offer. I declined it because I still had the vision of creating multiple clinics in multiple states where we would focus on diagnosing the source of the pain and again, fixing it so patients could go back to their chosen lifestyle and writing either no or reduced amounts of opioids. So then they asked me if I would agree to be an official White House presidential appointee. And I said, sure. What do you specifically want me to do? And they said, we would like you, along with other specialists in orthopedics, oncology, pediatrics, dentistry, Department of Defense, neurosurgery, Veterans Affairs, about 20 of us who are like-minded that we've identified in the United States to create the guidelines for how painful conditions should be diagnosed and treated. And I said, fine. And so that took us 2.5 years. We were very careful because we knew that we were going to be scrutinized with this document. And it's about, I think, 140 pages long. Almost 40% of it is bibliography. And so those guidelines, which we published through the U.S. Department of Health and Human Services, and it's called the U.S. Department of Health and Human Services Best Practices Pain Task Force Final Report. are still in effect to this day. And whenever something comes out of the U.S. Department of Health and Human Services, one has to watch, well, what's the response from the medical community? And something very special happened where 100%, not 99%, but 100% of medical specialty societies, and so I mean neurosurgery, orthopedics, pediatrics, OB-GYN, family practice, internal medicine, dentistry, emergency medicine, every single one of the societies in the United States endorsed those guidelines as being what should be followed. And so that indicated that our work was accepted. And so those guidelines, as I said, are still in force. Anyone, by looking online, by typing in U.S. Department of Health and Human Services, best practices, final report, it'll pop up right away and they can reference those. And so along with those guidelines, then I worked with multiple states and also now multiple senators to, on the state level, especially there were opioid settlements that occurred because of the various people in the industry had to pay for what their involvement in the opioid crisis, and then working with multiple governors on those, how those settlements should be allocated. First, if they should take the settlement in the first place, and many other issues. I continued my advocacy, and right now I am involved to some degree with events in Washington, and there should be an announcement forthcoming in the near future about my official capacity in Washington again.
That's so impressive, Dr. P. It's an unbelievable story.
Thank you.
Kind of to expand on that a little bit, treating the source of the pain, being, really ahead of the curve on interventional pain management. There's still critics to this day that say IPM is overly procedural, overly technology driven. What do you have to say to those critics?
Sure. So for the listeners, when you say IPM, you're talking about interventional pain management.
Yes.
And so that possibility exists. As I said before, within the structure of DxTx Pain and Spine, as I said, we have respect for physicians, board certified, fellowship trained pain physicians, but at the same time, we recognize that we have to be data driven, so that those people who are critics, we can point to peer-reviewed literature, we can point to scientific articles, we can point to data that supports what we do. And that's kind of what I alluded to earlier, where in the community, if a physician is on their own, we hope that they're ethical, we hope that they're honest, we hope that they're practicing state-of-the-art medicine, but we don't really know. Because, as I say, that network that we've created through DxTx Pain and Spine allows us for the transparency into their practice. And if we see something that one doctor is doing different from another and they're getting a better result, we take that doctor and we'll allow him to address all the doctors and physicians' assistants and nurse practitioners as a whole, saying, here's the data, this is what I'm doing. I'm getting exemplary results, or the other end of the spectrum, here's a new product. It has FDA approval, but we think there are other products that are better. So we've created an intellectual space that does not exist, at least to my knowledge, to the degree for diagnosing pain in the spine and other places in the United States. And it could be the world.
Well, speaking of the world, I jotted this question down after I saw a post you had on LinkedIn. I think you were in Lithuania. I've been on calls before where you've been out of the country. Like I've been visiting this regenerative medicine facility in the country. So it popped into my head, in interventional pain management, can you kind of compare what's going on with trends in the United States versus trends that you see internationally in your travels?
Sure. Great question. So every country in the world, I think, has issues with its healthcare system. I don't know of any country that I visited, and I visited many, that their healthcare system is not without fault. With regards to the state-of-the-art data-based practice of diagnosing and treatment painful conditions, I don't believe there's anyone better than the United States. I think there's countries that are perhaps as good, but no one better. I think that again, but having said that, it depends. With DxTx Pain and Spine, we have that ability to exchange that data among experts and create best practices. There are great advances in other countries. I was just in Lithuania recently, and just amazing stuff that they're doing in healthcare in the private sector with gene and genetics and viruses and just amazing advancements. So it's not to say that other countries are behind, everywhere, but in interventional pain management, right now, the United States is second to none when practiced in a data-based atmosphere.
So just about every week, Dr. P, I have fellows reaching out to me. So we can be assured that there's going to be fellows that are going to be watching this because a lot of them want to be a part of our network. They hear what we're doing, the amount of locations we have, the best practices, the synergies. What would you tell somebody in fellowship or recently out of fellowship, just entering this space, what to expect, or if they want to be change makers, what are they facing as they come out of fellowship?
Well, they're facing certain knowns, they're facing certain unknowns. And the unknowns are first personally, until you start practicing, until a physician starts practicing, they really don't know if the decisions they've made to that point are the right ones. And what I mean by that is there are some physicians who in the it could be for any specialty, but let's talk about interventional pain. When they get out and they start doing interventional pain, they somehow are not data driven. They are not, interested in using all the latest proven techniques to help a patient. And why that is, I don't know, because as I said before, there's a bell-shaped curve in human behavior. The second thing that they don't know is in entering a group, you don't really know the dynamics, especially in a smaller practice of, there are so many potential pitfalls now in healthcare that have substantial consequences, legal, medical legal, ethical, et cetera. So it's such a complex space right now with after you've committed to making the right diagnosis and make the recommended treatment, then we have this problem of insurance in the United States, where insurance companies each have multiple subcategories, multiple rules, what can be done, what can't be done, what time period has to go by before you can do something. Incredibly complex. And right now, practices have to be compliant. And if you're not compliant, it's so complex right now, there can be serious consequences. So a physician coming out of fellowship has the issues of within themselves, are they in the right space? And number two, did they choose the right practice? And it's very difficult for a fellow to make all the right decisions. They could join a phenomenal practice such as DxTx Pain and Spine, where they have support, where they have anything a practicing physician would want. But then they could realize, well, this isn't exactly what I wanted to do. On the other side, they could be someone who is really data focused, really up to date on all the procedures, which quite frankly, in a one-year fellowship is impossible. So I think all fellows know they have to get additional training once they're in practice, but they might be in a practice where they don't have support, either clinical or from insurance or from compliance. And so it's really difficult for a fellow, especially if he goes into a practice situation that's not like ours, that's across multiple states, that has multiple support. And I'm not saying DxTx Pain and Spine is perfect, but we are better than most because we have the resources to be on top of all these issues. So it's a complex problem for fellows. And I know personally, I enjoy engaging more with someone who has already been out in practice after their fellowship for at least a year, because then that individual knows, aha, I want to be in this space, or I want to be in this space, but I'm not right in the right practice, or et cetera. So it's a complex situation. And the best advice I could give a fellow is, in that first year especially, it might be you, it might be the practice, it might be both of you, it might be neither of you, but that's a year that's for continued growth.
Yeah, I haven't seen a fellow in their first year not run into some surprises or things that they didn't expect. Seen it
Right.
every time.
And again, that you hope that the surprises are those that are just, they didn't think of that, but everything is in that practice that they've joined is done ethically, is done properly, is done with the patient number one, on the thought process of the team, and that they're respected, and not that they enter a private practice, which, or any, or a academic practice where the way that the team that they join is practicing is not keeping their eye on the multiple problems that can derail the best practices for the patient with suffering with a spine or musculoskeletal headache or other related condition.
Knowing that nobody has a crystal ball, but you are somebody that has a lot of interaction with payers, government, practices all over the world, thought leaders. What are your thoughts on what's changing? How do you see interventional pain management over the next 3, 5, 10, 15 years? What do you think we can expect?
Well, I think on a clinical side, what's exciting is we're having improvements from data. And so maybe 3 or 4 weeks ago, I was a principal author among, I think there are 5 or 6 other contributing authors from DxTx, but also other thought leaders in the United States on the use of artificial intelligence and where we are and where we're going with spinal cord stimulation. I'm humbled. We worked on this paper for over a year. And so we put a significant amount of work into it, but now people who have read it have reached out to me and are very appreciative of what we've done. Because right now, the healthcare and artificial intelligence is something that is extremely not just discussed, but there are many entities that are working in that space. As I mentioned, I'm working in various capacities on several of them right now. So that article that we wrote, quite frankly, I was actually surprised. I knew we did something special when we submitted for publication and it was accepted. I wasn't ready for now the multiple requests from countries all over the world to come speak at their meetings on this topic. And I know I haven't shared that with you, Mike, but I'm getting emails from great places that are leaders in healthcare wanting me to come speak at their meeting. Asia, Europe, South America. I'm getting letters from editors of major scientific journals asking me to consider contributing to their journal the next time I publish something. So the healthcare AI space, the pain AI space is extremely exciting. And then also just data-driven care is going to just have to be at the forefront. And we have to keep very close eye on what's going on in Washington. And when we see that, if there are any cuts in healthcare that are relevant, especially to our patients suffering in painful conditions, we have to reach out to our leaders, our senators, our congressmen, because ultimately they're the ones who pass the legislation that comes out of the U.S. Department of Health and Human Services. So right now, Secretary Kennedy, Dr. Oz, other leaders can propose to Congress what needs to be done, but Congress has to vote on it. So an exciting time for interventional pain. And then on the clinical side, as we get more and more data and research, we're becoming more, I would say, interventional. Spine surgeons and neurosurgeons are becoming more minimally invasive, I guess is the word. And those two spaces are kind of converging right now into almost overlapping specialties.
Yeah, and you mentioned it You mentioned AI on a couple of occasions during this discussion, and I can tell you it's almost dizzying when I was at Becker's recently, the Becker's conference in Chicago, and thinking back to other conferences I've been at just a year or two ago, you'd see a little bit here and there, but the number of meetings requested from AI companies, the number of booth displays companies in AI is just growing exponentially. It's just really surprising to see how rapidly it's entering our space.
Right, and just like anything with rapid growth. I was asked to speak at the Becker's conference, and I've asked every year, but I was asked to speak at a conference in Europe, and I you can't be two places at once. So the European conference was very interesting on pain and spine care. But the one thing to remember with artificial intelligence, it's not magic. Being involved with several healthcare AI companies right now, there's variability of product strength. And so one has to be very careful in who they're engaging with because there can be they call it AI hallucinations, where the AI can take you down a path you don't want to be. It's an exciting space. You're absolutely right, Mike. Right now, in healthcare especially, the AI space is very exciting. Senator Rounds from South Dakota is one of the leaders in the Senate, working for legislation, and we have leaders in the House of Representatives as well. And so they're trying to do things the right way. Right now, you asked about internationally. Europe right now almost is an AI desert because the European Union has passed laws that really are against innovation. And so the AI companies that I'm involved with and many of the healthcare AI companies don't want to do anything in Europe, which I think the Europeans need to have a wake-up call because they're going to be left behind unless they change the rules in Europe right now, which are very unfriendly to prudent progress in the healthcare AI space.
Yeah, it's actually comforting in our network to see we have multiple physician leaders that are involved on a national scale with the AI space and staying ahead of the curve. So that's great to see with you, Dr. Bobby Mogum, Ramesh Geith. So we have it's great to see.
Yeah, right.
Um,
I think there's our most important national pain and spine organization now has selected 6 physicians for their AI committee, and 3 of those 6 are DxTx physicians. So I think to have 50% representation on a committee of that significance speaks volumes to the forward-thinking nature of DxTx Pain and Spine.
yeah, that's awesome. That's awesome. Couple more questions. I've been with DxTx for about 3.5 years, and I've been in a lot of meetings with Dr. John Prunskis. I've been to a lot of national conferences. I've seen you speak. I've seen you stand your ground up on stage, always with passion and energy, and just a lot of enthusiasm. How do you recharge? What do you do to keep yourself as engaged and excited about what you do every day? What activities, what hobbies, what do you do?
Sure. Thank you. So I have great passion for diagnosing and treating painful conditions. Love is a very strong word. Maybe I really like knowing that the first day that I see a patient is perhaps their worst day, because as I'm with them, or a DxTx physician or teammate they're going to be getting better with time. So that's great. The second thing that fuels me is data-based innovation. And so just as for 20 years, and you have to remember, 20 years, it was difficult for 20 years to be a contrarian, but the data supported my position. I remember getting hung up, primary care doctors calling me in that 20-year period saying, Prunskis, my patient needs more opioids. If you don't write them, I'll find another doctor who will. And they'd slam the phone down, and they would find another doctor. And I knew, financially, there was a loss because I lost that whole referral source. But I knew that what we were doing was right and focusing on fixing the source of the pain. So right now, I have developed a reputation that, in Washington and elsewhere, that I'm data driven. And so now when there's an innovation that's as huge as artificial intelligence, I feel an obligation to stay data driven, but an obligation also to be forward thinking. And so that's what keeps me going now is in healthcare and AI, and also now longevity was fueling me. So helping people find the root cause of their pain, fixing it, getting them back to their life, and then tying that in with continued advancements in data, continued use of prudent artificial intelligence, tying that in with now data-driven longevity, what we can do to ourselves. And so specifically, every day now I'm exercising at least 30 minutes a day. Some days I'll miss that, but that's a target, and it'll be 30 to 60 minutes if I can. Changing my diet, specifically, eating more plant-based, fish, less red meat, less junk food. But, I'm from Chicago originally, so I still like a good pizza. So once in a while having that, but that's what keeps me going. And I was at an event this last weekend where there are some people that I haven't seen for a long period of time, and they said, "Wow, you look really good." And they said, "What are you doing?" I said, "Well, I changed my diet. I've changed other things. I changed, my exercise habits. I've lost weight." Because these are proven techniques in longevity medicine that will extend someone's life. Not to mention, if they have a painful condition, weight reduction and sleep and exercise and all that is going to help, in many cases, reduce the excess, as I say, weight that can cause back pain, et cetera.
That's inspiring. As you know, I've had some health issues over the last year and a half, and kind of on that same path too of trying to eat better, lose some weight, exercise. So that's great. That's inspiring. Now, since we are talking about food, and you do travel, and I travel a lot too, the three places I've seen recently: Chicago, you're in Florida now, and Lithuania. Off the post that I saw, favorite dishes in Chicago, favorite dish in Florida, favorite dish in Lithuania.
Okay, so I'd say the favorite dish in Chicago has to be the pizza, both thin crust and deep dish and everything in between. But now Chicago is a great culinary town. Don't get me wrong. There's all kinds of stuff, but you've pinned me down to one to one to one food. In Florida, it would have to be the seafood. We're right on the ocean. Catch of the day, going to the grocery store and asking the person behind the counter, the fishmonger, what came in fresh today. So that'd be seafood. And in Lithuania, it would have to be a soup. In Lithuanian, it's called šaltibarščiai, but it's a cold beet soup that looks a little bit like Pepto-Bismol, only because the beets are in it. But it's a combination of kefir, which is a kind of a buttermilk, a yogurt, milk type beverage, beets, and vegetables such as cucumbers and things like that, and other fresh vegetables, is just delicious, nutritious, and is healthy. And so those are the three. But obviously, each one of those geographic localities has multiple other dishes that are outstanding, but you've pinned me down to one in each location.
That's fantastic. I tell our executive leadership team, I said, I always learn something every time I talk to Dr. P. We have long discussions or debates sometimes, and I always learn something. I've learned today about Lithuanian soup, beet based that looks like Pepto-Bismol. So I've absolutely learned something new today.
It
Dr.
tastes
Prunskis,
amazing.
I bet it does. I bet it does. I definitely love food. Hey, thank you for your time. This is fantastic, and it can, you know, educate people on interventional pain management from one of our national thought leaders is just fantastic. And glad to be a part of DxTx, and glad you had that vision. Thank you.
Thanks, Mike, and thanks for all you do as well.